Good morning, everybody. My name is Paul Malloy. I'm the CEO at ClearFlow. We're very proud this morning to welcome Dr. Marc Gillinov, the Chief of Cardiothoracic Surgery at the Cleveland Clinic. Dr. Gillinov will be presenting a clinical talk on his experience and the importance and benefits of avoiding chest tube occlusion to prevent the inflammatory consequences of retained blood after cardiac surgery. I'm sure everybody knows Dr. Gillinov from his work. He's done thousands of patients in surgery at the Cleveland Clinic with excellent outcomes, one of the top cardiac surgery centers in the world. He trained at Johns Hopkins and finished top of his class there. As you may know, he's also a regular presenter in the United States on television on health matters and is a published author, as if being the chief at the Cleveland Clinic wasn't enough. So we're very happy to have Dr. Gillinov today presenting to the United States, to Europe, and to participants at the Arab Health in Dubai. And with no further ado, I will hand the clock to Dr. Gillinov for his talk. Thank you very much.
Thank you. It's great to be here and there. Here for me is Cleveland, there for you is Dubai. Cardiac surgery is complex and challenging, but today I'm going to tell you about something that is simple and easy, specifically making sure that we have good drainage after cardiac surgery. We all know we do our operation, whether it's bypass surgery, mitral valve surgery, robotic sternotomy, doesn't matter. We always leave a chest drain. And you do that in general without thinking too much, because what could go wrong? It's just a tube, it's hollow, it's going to drain, but it doesn't always work. The problem that we all know is that these tubes clog, they stop draining, blood, fluid accumulate, and that causes problems. And some years ago, actually more than a decade ago, some colleagues and I, Ed Boyle, John Liddicoat, myself, and others said, well, wait a minute, how hard could it be to keep a tube patent, to keep it draining? And we had the thought, but now these smart scientists from PleuraFlow have the solution. So we'll go to the next slide. Everyone who has heart surgery has some shed blood. We're working on the heart, we're working on the aorta, blood vessels, and we're anticoagulating people. And that's why we leave chest drains. And the same thing after general thoracic surgery, same sort of deal. We want to drain the pleural space, we want to drain the pericardial space after heart surgery. And if we don't drain, then the blood is retained, and this will often lead to reinterventions. There are a lot of people who have had heart surgery who have needed subsequent drainage, pleural drainage, pericardial drainage, and even Bill Clinton, former president of the US, had heart surgery, not here, but in the US, and he had retained blood and had to go back for decortication sometime later, which is, if you ask him, he would say that was no fun. If the drainage had been better, perhaps that wouldn't have happened. Next slide. So today, our residents or we ourselves get called to the ICU, and the nurse will say, the chest tubes, they stop draining. And then your question, my question is this tube clogged or blocked and the patient's still bleeding inside? Or alternatively, is the tube patent and there's just no blood coming out? And what happens is that we start putting catheters up the tube. We try to milk it to get the clots out because we presume there are clots. And the nurse is working on it, we're working on it. And it's really a waste of time. There are a lot more important things to do for a fresh open heart patient in the ICU than try to figure out how to get the clot out of the tube. And it's hard once the tubes are clogged to get the clots out. And if we can't get them patent, then we've got complications related to delayed recovery, increased costs, increased morbidity, and in some cases, even mortality from tamponade or subsequent infection. Next slide. So we've all seen pictures like the ones we just showed of the tube is pulled the morning or 2 days after surgery and it's filled with clot. How often does that really happen? That was a good question. We've got an answer. We got the answer by looking at 150 patients who had heart surgery a couple days or a day previously who needed a CT scan for another reason, maybe suspicion of pulmonary embolism or some other reason. They went to the CT scanner. Then we went back and looked at all the tubes that were indwelling on all these patients and asked the question, how many of the tubes were occluded? How many were patent? Next slide, please. And what we found was that 36% of patients, so more than a third, their chest tubes were absolutely occluded. They were doing nothing. They were still in, they're still in the patient, still in the chest, still causing pain, but doing nothing whatsoever. And interestingly, 86% of the time, so basically 9 out of 10 times, the occluded chest tubes were occluded on the inside, and on the part we could see, the tubes looked fine, but they weren't. So basically the message here is that lots of tubes occlude, more than a third, and we can't tell, we can't see. So what happens when the tubes are occluded? Well, a lot of patients do fine, but a lot of patients don't. 20% of the patients who have an occluded tube run into problems from retained blood. And then they need reinterventions. They need thoracentesis, pericardiocentesis, insertion of a pigtail or even a chest tube, or re-expiration. So it is not benign to have an occluded tube. And if you sort of look at the time frame over which these complications occur, so time is moving from the top to the bottom. You see green is immediate and gray would be in months. So as you move from the top of the screen to the bottom of the screen, time is elapsing. Look at the left. If you have adequate blood evacuation, meaning your chest tubes work, your chest drains are effective, you recover. So that's great. That's what we all hope for. But hope is not a strategy. You need to make it happen. If you don't make it happen, meaning if you don't have good drainage, if you don't ensure good drainage, then you're over on the right side where you've got inadequate blood evacuation and all the complications that fall. So if you've got a lot of bleeding early on, this leads to acute RBC, retained blood syndrome. This occurs maybe in 1 in 15, 1 in 20 patients. And there you've got tamponade or hemothorax, and that can lead to another trip to the operating room. But let's say you've got a patient who didn't get these acute problems, but still there was retained blood in the pericardial and pleural spaces. Then you're more to the right of the screen. And in yellow, you can get sort of a subacute problem. Patients still in the hospitals, post-op day 4, 5, or 6, and they've got a pleural effusion or a pericardial effusion, and they need to be drained. And now you're saying, all right, are I going to be able to do this percutaneously, thoracentesis, pericardiocentesis? Do we need to return to the operating room? Do we need a VATS procedure? And that occurs in 10, 15% of patients. To us, the surgeons, it's a modest complication, but to the patients, it's a disaster. The patient thinks I was recovering better. I was on my way home. Not so fast. I'm not on my way home. I need another procedure. And then some of these patients slip through the cracks. They have, let's say, a moderate pericardial or pleural effusion. They don't need anything done acutely, but 2 to 3% go on to get constrictive pericarditis, or as Bill Clinton, former president, got a fibrothorax, and then they need a big operation. So you don't want to be to the right side of this screen. You don't want to get down to the orange, yellow, or red, where you have complications that were preventable and that lead to morbidity and subsequent procedures. Next slide. So that's the problem. The consequences, we've gone over sort of generically saying these things happen. This slide tells you how often. In red, we see results in patients who did not have retained blood, their chest drains worked. And in gray, patients who had retained blood in the mediastinal or pleural spaces, and what happened to them? What did the retained blood cause? And moving from left to right, 36% higher incidence of postoperative AFib, 39% increase in time on the ventilator, 162% increase in infection, longer length of stay, associated with even increased mortality, and subsequent readmissions for problems related to retained fluid like pleural drainage, pericardial drainage. So it's not benign. It is a preventable problem. It's a real problem. It's a costly problem, no matter how you adjudicate the cost, whether you talk about dollars, whether you talk about length of stay, whether you talk about pain, suffering, and fear on the patient part, there is a cost to retained blood. Next slide, please. Well, a lot of surgeons say, I don't have that problem. Think about it for a minute if you're one of the surgeons who says that, because I was initially one of the surgeons saying, oh, that's not a problem. I fixed the mitral valve, the echo looks great. That's something that doesn't happen. And if I say that to myself, I am lying to myself. If we look at a whole bunch of studies, just 6 of the many studies here, and ask, how often do cardiac surgery patients have problems, have complications related to retained blood in the pleural or pericardial space? The answer is about 20%, 16 to 20%. There's not a single series that looks at this that says it's less than 10%. So it's about 1 in 5 patients has this preventable issue, preventable being the key word, from retained blood. Next slide, please. Now, I mentioned that the big ticket items with heart surgery are things like, did you survive? Did you have a stroke? Did your valve get repaired? Did you get all arterial grafts? So those are all things that we as surgeons think about all the time, and we know how to handle. But what about the other things that cause problems for the patients? And this is an editorial about what we could classify as I wouldn't call them minor, but other post-operative morbidities that we should not neglect, because they are a big deal for patients. And look, frankly, if we as surgeons are trying to compete with catheter-based procedures, we've got to avoid these morbidities that we consider minor: pericardiocentesis, pleurocentesis, chest tube insertions, pericardial drainage. These are all things that don't happen with catheter-based procedures. And if we allow these events to remain part of the surgical package, then we are really harming ourselves, our practices, and more importantly, our patients, because we're not doing the best job that we can. We're leaving them with morbidities that we can largely prevent. Next slide. Now, we've got some excellent data to link RBS, or retained blood syndrome, with a lot of different problems. One of the most interesting to me is post-op AFib. To the right, we see a cover from the Annals, January 2018, which goes over the pathophysiology of how blood in the pericardial space causes post-operative atrial fibrillation. And the science is really elegant and very clear. If you leave blood around the heart, whether it's in a patient or in an experimental animal, if you leave blood around the heart, it causes inflammation, which leads to post-op AFib. Then just a couple months ago, this study was published in The Lancet. And in this study, what they did was they did a randomized control trial. Actually, I was part of the study. Randomized control trial, creating an incision in the pericardium on the left side to drain the blood from the pericardium into the pleural space. And lo and behold, if you get the blood out of the pericardial space, you drain the pericardial blood, you have less post-op AFib. So to the right, the science; to the left, the proof that blood in the pericardial space causes more post-op AFib. Draining the blood from the pericardial space reduces the incidence of post-op AFib. Next slide, please. So we'll look a little bit at the science. Retained blood in the pericardial space leads to inflammation and tissue damage at the surgical site. And this is all the kind of stuff my kids are learning in medical school. You activate free radicals, the NAD pathway, etc. But basically what you wind up with is some tissue injury and inflammation at the atrial level, which leads to post-op AFib. And again, this is the science well worked out. We also have the proof that draining that blood reduces the incidence of post-op AFib. And once again, when we say post-op AFib, we're ourselves probably thinking, not too big a deal, it's just AFib. Well, it actually is a big deal. It increases length of stay, it increases the risk of stroke. Post-op AFib is associated with long-term morbidity and even increased mortality. So the message here is anything we can do to reduce the incidence of post-op AFib is going to reduce costs, reduce morbidity, and improve outcomes. So next slide. So here's one thing we can do to drain the pleural and pericardial spaces better. This is the PleuraFlow system, and it has a chest drainage catheter that we can floss or keep clear because there is a catheter that extends in the lumen And we can use this with magnetic control to move the clearing or flossing catheter up and down the tube to floss it out, break up clots, which are then sucked out. And this is FDA approved in the US. And it comes in a variety of different sizes. I personally, here at the Cleveland Clinic, we use more of the straight tubes than anything else. But some of the guys prefer a right angle tube. And one of the things I've only come to realize recently is I should leave these tubes in for a couple of days, because let's say I've got a patient who is having some bleeding, and all cardiac surgery patients who have some bleeding, and I take it out really quickly, post-op day 1, maybe after 16, 18 hours, I could still have some weeping into the pericardial space, and I have removed my solution to the problem. So I've started leaving these for a couple of days, and my friends at the Mayo Clinic leave their chest drains for a couple of days as well, to ensure that we get good drainage. And again, I like the long, straight, and a smaller size. One of the nice things is that a smaller size drains just as well as a larger size. So a smaller size tube that you know is going to stay patent is associated with reduced pain for the patient, and we still drain the pleural and pericardial spaces. Next slide, please. And this is what you see. Each one of these panels shows a standard or conventional drainage tube from a patient, and then with the blue arrow, a PleuraFlow active clearance technology tube from the same patient. So the patient serves as his or her own control. And what you see is the conventional tubes filled with clot. We already knew that from our CT study of 150 patients. The PleuraFlow tubes, largely no clots. So they are clear. And that's what we're looking for. What does this drainage benefit result in? Well, if you start at the top left, ICU length of stay is reduced by 32%. Move to the top right. Patients who are in the ICU more than 3 days, reduced by 36%. Ventilator time down by 20%, moving around clockwise. And overall length of stay down by a day. So patients are getting out of the ICU more quickly. They're on the ventilator for less time, and they're getting out of the hospital more quickly. And this very quickly adds up to cost savings and increased patient satisfaction. Next slide, please. So we've got a whole bunch of studies now in the literature, peer-reviewed, looking at the benefits and documenting the benefits. Overall reduction in retained blood, pleural and pericardial effusions, 43 to 91%. Reduction in post-op AFib, consistent across many studies, 18 to 33%. And of really tremendous importance, dramatic reduction in re-expiration for bleeding. And I actually have an anecdote of one of my patients. I was at dinner, and the resident sent me a screenshot, a picture to my phone of an x-ray of one of my patients whose chest was whited out. So the patient had been bleeding, hematocrit falling, and you could see the right chest filled with blood, whited out. And he then called and said, "Did you get the picture?" And I said, "Yes, I see the picture." He said, "Well, we're going to have to take the patient back to the OR. I alerted the OR. We should be going back soon. Don't worry, you can stay at dinner. I don't have to come in. You don't have to come in. I'll take care of it." And I said, "Well, did you actuate the tube, the PleuraFlow tube? Did you floss it, clear it out?" And he was new. This was in July when we have new residents. And he said, "Well, no, what is that?" And I said, "Go talk to the nurse. They'll know how. They probably got distracted with something. Maybe another patient was doing poorly. But if you just floss the tube out, you will drain that effusion." Because it was the night of surgery, the effusion was still just liquid blood. And I said, "All right, call me back in 10 minutes. I bet you're going to have good news for me." So he called me back. Actually, first he sent me a new picture, which showed a clear right chest. I could see the lung markings, it was black again. They called me back and said, "It worked." I said, "Yes, I thought it would work." And he said, "That was really cool." I said, "Not only was it really cool, you saved the patient going back to the operating room, probably saved yourself, because now you can go to sleep. Because don't worry, should the patient be bleeding," and we did have to correct the coagulopathy, but correct the coagulopathy, we will not have to return to the operating room. And that's an N of 1, that's an anecdote. But in the right panel, what you have is real data. This patient was one of many who did not have to go back to the operating room because we had active clearance technology. Next slide, please. And 72% reduction in take back for bleeding. And if you think of no other reason to use this technology, and I use it for all the reasons we've been talking about, but if there's no other reason than to save patients a return to the operating room, it's a darn good reason. You get reduced post-op AFib as well. You have patients with reduced pericardial effusions, pleural effusions, but this is a biggie. Failure or not need to return to the operating room the night of surgery is extremely important. And actually the fact is, and we all know this, we cannot reliably predict who's going to bleed after surgery. Because if we knew someone were going to bleed after surgery, we would have stayed in the operating room to keep them dry. I mean, obviously you've got some complex redos, some LVADs, maybe some heart transplants in a reduced setting where you know you're going to have more bleeding than average. But this happens to the routine CABG, the aortic valve CABG, the robotic mitral. We will have bleeding in heart surgery. And even in the patients who are as dry as can be at the end, we don't know for sure that they won't bleed. They all bleed some. So got to be conservative and anticipate potential problems in management. And if you do it, if you look at this as data from a very large series, showing again the benefits, reduction in post-op AFib by about a third with a significant p-value, the same story over and over. And I know this might be getting a little bit repetitive. It's repetitive because it's consistent. Post-op length of stay down by a day, percutaneous interventions, that means thoracentesis, pericardiocentesis, less frequently required, and overall retained blood far less frequent. Why? Because we had good drainage. And then as far as the hospital is concerned, hospital administrators, healthcare payers, big savings, about $2,700 per patient by the simple maneuver of draining the chest well. Next slide. So length of stay down by a day, retained blood syndrome almost cut in half, take backs down by 72%. And these are the kind of data that have resulted in this concept being introduced to our guidelines. It is obviously very important, class 1 indication, maintain chest tube patency. I mean, that's why we put any sort of drainage in. And then we don't want to do this by stripping or breaking the sterile field to remove the clot. We saw that all tubes get some clot, 36% of them become completely occluded. And once a standard tube is occluded, we're a little bit stuck because we don't want to strip it, we don't want to break it. Those can introduce infection or harm mediastinal structures. So the best idea is to make sure that we've got the ideal technology to keep all tubes open from the very beginning. And the reason I use this in every cardiac case is, again, I know every patient is going to bleed some. I can't reliably predict which ones are going to bleed the most. So I've got to be conservative and do something very simple. I said at the beginning, cardiac surgery is complicated. It is. This is simple. I want to do something very simple and very effective to protect my patients from the outset and use it in everyone. And second to last slide. So it's the analogy of a seatbelt. It is the law, just like we have laws in life, we have guidelines in surgery and in medicine. It is the law that we wear a seatbelt because we don't know if we're going to crash. Ideally, we're not going to, but when it does happen, you'll be very glad you're wearing a seatbelt. So I want to be very glad that I have the prophylactic maneuver, the easy, simple way to prevent the problem rather than wait for the crash or wait for the fire extinguisher when the crash or fire extinguisher is already in play. So we want to prevent complications. We want to enhance our patient's recovery. We want people to do better. We don't want to be up in the middle of the night having to do a take back when all we needed was good drainage at the very beginning. So this is a really simple means to protect our patients. And the final slide, please. We want our patients, after going through such a big operation, to have a seamless recovery. Heart surgery is a very big deal. We have solved many of the largest problems in heart surgery. Mortality is low. Strokes are uncommon. Mediastinitis, very infrequent these days. But again, to the patients and to the payers, these other complications, needed to do a pericardiocentesis, needing to put a chest tube, return to the operating room the night of surgery, these are all still things that happen with unfortunate regularity, and we need to do everything we can to prevent them. And again, from the complex to the simple, this is on the simple side of the equation. We can make patients do better with one simple maneuver, achieve good chest drainage. Thank you.
Thank you, Dr. Gillinov, for that excellent talk. We have also present on the webinar Dr. James Holofsky, who is the Director of Clinical Training and Education at ClearFlow. And I just would like to remind the audience that ClearFlow was co-founded by Dr. Edward Boyle, who is himself a cardiothoracic surgeon. So the roots of this company are in cardiothoracic surgery, and our history and clinical research has only been working with cardiac surgeons for the benefits of our patients together. And I'd like to throw the floor open to questions for Dr. Gillinov or Dr. Holofsky this morning before we close the session.
Thank you, Paul. We actually have a question from David Koolbergen in the chat here. I don't know if you'd like to try and field this, Dr. Gillinov. It's basically says, how is this perceived at the ICU level with the need to manipulate or actuate every 15 minutes?
It's just part of the workflow, and it takes literally 10 seconds to do it. So it's much preferable to the nurses to do this, 3-4 times an hour. And we reduce the number of times we actuate it as the patient recovers. So for the first 2 to 4 hours, we do it 3 or 4 times an hour. But anyway, from the nursing perspective, they love it because much easier to do this for a few seconds every 15, 20 minutes than to have to deal with the clogged chest tube at 2 in the morning where they're trying to call the resident, call the attending, and they can't get it open, and then they're packing up the patient for a return to the OR. So it becomes sort of preventive maintenance, but because it's so simple, they like it.
Thank you, doctor. And the only thing I would add to that, for your sake, David Koolbergen, is there's actually a paper by actually a colleague of yours, Dr. Gillinov, over at the Cleveland Clinic, Maya Cook. They did a, and I think you were on the paper as well, where basically they looked at the amount of time spent by the nursing staff in the ICU following cardiac surgery. And one of the things they found was obviously when they do have issues with chest tube maintenance or the ability, they don't have the best ability or the best tools to be able to deal with that. They actually ended up seeing that many of the times nurses end up spending an hour to an hour and a half post-surgery just maintaining the chest tube patency or trying to maintain patency with that chest tube, as opposed to, as you said, periodically doing an actuation that takes only 10, 15 seconds, and then preventatively or proactively maintaining that chest tube patency as opposed to reacting. So hopefully that answers your question there, David.
Unfortunately, it's very intuitive. It's just flossing out a hollow tube. So there's next to no training necessary for it, and that's a good point.
See if there's any other questions here. I think we do have another question here. It says, first hour is Q15 minutes, and then how often after the first hour, from an anonymous attendee here.
We'll do it every 15 minutes for the first 2 hours. And then we look at the patient and do what we do in medicine, which is reassess the situation, see where we are. And if the patient is having very little drainage, then we'll go to every 30 minutes for a couple of hours, and then every hour. On the other hand, if you've got someone, say it's an LVAD in a redo situation, and they're still bleeding a fair bit at the end of 2 hours, we will be doing it every 15 minutes thereafter. And again, it's not so much about the time because it takes almost nothing, but in these kinds of situations, you're keeping the patient alive, preventing a take back to the OR and giving yourself the time to correct the coagulopathy while ensuring that you've got good drainage.
Thank you, doctor. We have another question coming in. It says, if tubes clog 1 out of 5 times, why are the symptoms occurring less than that? Example, subacute complications of RBS being roughly 10 to 13%.
let's say you've got a patient who's bleeding some and the tube clogs, and that patient bleeds a fair bit thereafter, but you don't know because your tube is clogged. So that patient is going to be on the way to needing something done, whether it's subacute while in the hospital, pericardiocentesis, pleuracentesis, or maybe later gets fibrothorax or even worse, constrictive pericarditis. So that's the bleeding continues. Now let's say you've got a patient who is relatively dry, the tube clogged, and again, you don't know it's going to go like this, but let's say the tube clogged, but the patient didn't bleed much. That tube gets pulled, it was clogged, but there was very little retained blood, it resorbs, and that patient does not have a complication. The problem, though, again, is I can't and you can't predict who's who. Let's say a third of tubes clogged, some of those patients are going to do just fine. They didn't bleed much, their tube was clogged, but they didn't need it anyway. And some of them are going to get into trouble, and we can't tell which one is which. So the best strategy is to achieve good drainage in all of them from the outset.
Just to annotate that point, the data showed here represent interventions, not complications. The complication rate is actually much higher than the intervention rate. In the Nuremberg study at Paracelsus Clinic in Germany, the complication rate was 29% in a 600 plus patient cohort, and the intervention rate was about 19%. If we look at Medicare claims data in the United States, the readmission rate for cardiac surgery patients at 30 days, looking at 600,000 patients, is indeed 1 in 5. So there is a strong correlation between chest tube occlusion and readmissions and complications. Of course, not all complications are treated with an intervention. As Dr. Gillinov pointed out, some patients go home with pleural effusions, and some surgeons are happy to leave those resolved by themselves, and that may take 2 months or longer and leave the patient with long-term problems. So bear in mind that we're talking here about interventions based on codes that we can identify, not just complications, which sometimes go untreated for some longer period of time.
Yeah, that's a very good point. My father was sent home with a moderate pleural effusion some years ago, and then he needed a thoracentesis, and it recurred. This was before we had active clearance technology. It recurred and they let it resolve, but he was short of breath for about 3 weeks.
I don't see any questions coming in. If anybody does have any, please go ahead and type them in. Oh, here we go. We got another one. From Brad. Hey, Brad. This seems so obvious. What will it take to make this a global standard of care, even in developing markets, in your opinion, Doc?
I think the first steps have been completed and those boxes checked to prove that it's a problem. Because again, a lot of surgeons don't yet accept the notion that this is an issue, even though they've pulled tubes themselves and they've seen it filled with clot. So first surgeons will say, wait a minute, I need to look at this data. And yes, 36% of tubes clog. Lots of people get pleural effusions, pericardial effusions, post-op AFib, and later complications. The second step, which is already completed, is to demonstrate that we have a solution that works, which is why I use these, and we use them at the Cleveland Clinic routinely. And then the third step was to have guidelines recognize it, which ERAS has. And I think now the fourth step is just to continue to get the word out. Of course, more studies, more publications will help. But I mean, as far as I'm concerned, it is standard of care. I agree with the ERAS guidelines. It's standard of care to have your chest tube patency maintained. And this is an excellent way to do it.
With those closing comments, we will adjourn the session. Again, with sincere thanks to Dr. Gillinov, who has a busy schedule at the Cleveland Clinic. We're very appreciative of your real-world experience and your credentials for teaching here today, and I'm sure the audience also appreciated that. So thank you, everybody, for joining. This webinar will be available as a recording, and please contact Dr. Holofsky at ClearFlow for your copy, and we'll be reaching out to you individually as needed. Thank you very much, everybody.